How can we border the thoracic wall? And how can we border the thoracic cavity? Where it starts and where it finishes? It was a question. Where are the borders of the thoracic cavity?
The diaphragm is the lower border.
The diaphragm is inside, but you look at your patient. Please look here. Firstly, your patients and we have skin. If you are speaking about the diaphragm, you need to make the incision. So where is the upper border of the thoracic cavity?
Clavicular.
Clavicular line, then?
And axillary line.
No, maxillary line is the area of the head. Head, where you have brain, I hope. Okay, let's go inside. Where is the borders of the thoracic cavity?
The mediastinal line.
Where is mediastinal line?
Next to the linea alba, the middle.
And it's a border?
Yeah.
Border of what? Mediastinal line.
Of the thoracic.
Okay, then. What else? It's not enough. Look at the screen. We are all live and work in 3D space, so it's not enough to name only the anterior line, mediastinal, but also you need to look at the posterior axillary line. It will make you borders from the anterior to posterior space. If we look inside, the lower border will go through the diaphragm, and the upper border will go through the subclavicular line. So we have this box which includes which structures? What do we have inside?
Lungs, of course.
What else?
Pleura. We have.
What else?
Arteries and veins, lymph nodes.
Well, arteries and veins can be everywhere. In the finger, we also have an artery and vein and lymphatic nodes and nerves. Which organs are very specific?
Rib cage. Ribs.
Inside or outside?
Outside.
Outside. But inside, what do we have?
Heart.
Okay. What else?
We have the.
Which parts of the aorta we have inside?
Ascending aorta.
Ascending, arch, and thoracic aorta.
Yeah.
We have thoracic part of the esophagus. We have superior part of the vena cava. We have some branches of the vagus nerves, like recurrent. Correct. The bronchs.
Yes.
Okay. So, shortly about lungs. What is the difference between left and right lungs? At this cadaveric material, you can easily recognize that left and right lungs have different numbers of the lobes.
Right lungs have 3 lobes, and the left has 2 because of the heart.
Because of the what? Well,
Heart.
But heart has connection with the right lung also.
Yes.
Which part of the left lung is located in the area of the middle part of the right lung? Let's say in this way. Because the left lung, more or less, can have the middle part. But this space is made by some area of the heart? So which?
Epicardium.
Well, the most area and square of the ventricle has the depression to the lungs, so it should be a little bit smaller, and that's why the pneumothoraxes and different disorders with the left lung always has the worse prognosis if we compare it with the right one. So next, what do we have inside the intercostal space? This question will be very important when we discuss the thoracentesis and pleuracentesis. Pay attention to this abbreviation VAN, vein, artery, and nerve. So this triplex goes at the inner surface of the upper rib. So this area is very dangerous if you make some injections, incisions, or if you make some costal resection. According to this presentation, please tell me where is the safe place for injections? Through which surface of the ribs we should make injection to the thoracic cavity?
Through the space between the two ribs.
Okay, once again.
Through the space between the two ribs.
Exactly where? Once again, pay attention to the dangerous place. We have two ribs. I will draw at the picture. Wait. Okay, it will be green marker. Okay, please look. Do you see the green region?
Yes.
Yes. Yes.
So we have two parts and two ribs, the upper and lower rib. At the internal surface of the upper rib, we have the triplex of the vein, artery, and nerve. And
Yes.
at the upper surface of the lower rib, we have only connection of the muscles. So
Yes.
our needle can go, let's look,
The
Lower.
lower.
Yeah,
Yeah.
lower.
here, but
Yeah,
it
yeah.
is strictly forbidden to go here because
Got
the
artery is
the
Because
anterior,
it is artery nerve.
before the artery, firstly, we will find the sharp area of the upper rib. You can see
Yes.
it's like
Arch.
it's like a sheltered semi-arch which protect these triplex. And after that, we will find artery, nerve, and vein, artery, and nerve. And according to this picture, you can easily prognose why it is usually why nerve is usually damaged, but not the artery and nerve, artery and vein. Why nerve is damaged in most of cases?
Because nerve is the first part from down.
Yes, because it's lying a little bit superficially according to the blood vessels. And when we make resection and the way we make injections, we always need to make the palpation to understand where is the proper surface of the rib. Let's look. According to the pectoral fascia and to the pectoral muscles, we can predict where the pathway for the inflammatory fluid can go. We will discuss shortly other time about the inflammatory processes of the mammary glands. But please look at these cadavers. What do you see and how you recognize these yellow tissues? What are they? So we see muscles, they are red.
Subcutaneous
and
fat.
This is subcutaneous fat. And between this fat, we can find different septors. It is here, please look. This fat can separate also the layers of muscles, and the pathway for the inflammatory fluid can be directed through these areas. Also, how we have connection between pectoral small and pectoral big muscles. Which muscle is more superficial and which muscle is deeper? Can you
Deeper is
remember?
intercostal muscle.
No, we have two muscles, pectoral major and pectoral minor. So which
Pectoral
muscle is much more superficial, major or minor?
Minor.
Minor.
Okay, the inflammatory process is located under the pectoral minor muscle. Where it can go?
Means the pectoralis major or minor or major. Go.
Where else? Okay, it is correct, but where else? Okay, let's pay attention at another area. In general, when you have a question at the exam and when your teacher is asking you where is the pathway for the inflammatory liquid, you can know or you can forget the title of muscles and layers and so on, but please remember that if in front of the abscess or phlegmon or other inflammation we have neurovascular bundle, it means that first direction will be via arteries and veins or nerves. After that, it can go to the layers by channels or foramens. But firstly, the very direct connection from point 1 to point 2 is neurovascular bundle. So, according to this, can you remember the blood vessels which give the proper blood supply to the pectoral muscles?
Thoracic artery,
which we will find the internal thoracic artery, which goes at the lateral side of the sternum, and also in lateral side we will find lateral thoracic artery. So the most dangerous for the question of pectoral phlegmon will be lateral thoracic artery. Via this artery, the inflammation will go upper to the axillary fossa, to the subclavian region, and so on, upper to the projection of the head. Let's look at the inflammation inside. At this picture, you can find the patient with the abscess in his pectoral region. At the left side of the screen, you see the projection, firstly, of normal anatomy of the thoracic wall. We can find the skin, fat, fascias, then layers of muscles. Firstly, we find the pectoral big or major muscle, then we find the pectoral minor muscle, then intercostal space between ribs. At the middle picture, the initial condition, this you see, I will write letter V. Do you see? Do you all see the picture?
Yes, yes.
Okay, this green means infection. So this infection is located between pectoral major and pectoral minor muscle. So the title for this disease is subpectoral abscess or subpectoral inflammation. And lastly, if we do not treat this patient, the inflammation will go deeper below the minor pectoral muscle to the retromammary to the retromammary space, and after that it can go through the intercostal muscles inside the thoracic cavity. According to the presentation at the right side of the screen, you can easily predict in which area that patient had initial process. Look here. Where he had this process, in which layer? Hmm? Are you here?
Yes.
So where we had the inflammation, in which layer?
Just below the subcutaneous, because if in the muscle, between the muscle, we couldn't see that because they were to flow down.
Yes, this disease was very superficial, and the nature of this inflammation was firstly the subcutaneous fat or adipose tissue. Maybe inflammation was located in front of the hair follicles, or maybe some other injuries, but we see at the initial picture that there is no damage for the skin, so it was initial inflammatory process, and treatment was in the next way. It firstly incision, then clearance for the necrocyte tissues, and after that drainaging, antibiotics therapy, and so on. Let's go a little bit to the intercostal space again, and this is another presentation and another vision for the intercostal space. You can see much more information about branches of the nerves and where we have these branches. Firstly, in the neurovascular bundle, which is lying below the lower surface of the upper rib. It goes through the anterior cutaneous branches, and also we have anterior and small collateral branches which goes inside the muscles of the intercostal space. So if we damage this muscle, what your patient will tell you? Which clinical sign will be very typical for patients with such damage? They will feel pain or muscle disorders.
Muscle disorder?
Are you sure?
Ben.
So these nerves goes from which part of our neural system? Autonomic or parasympathetic or brain? It will go, it will make both sensation, not only muscles, but also sensoric or pain sensation. If we need, let's look here. The very nice cadaveric preparation. So what do you see? At the right side of the screen, which nerves can you find here? Firstly, long thoracic nerve. And also, can you find the cutaneous branches? No, you can't, because
No,
they are
because it's inside.
Yes, because firstly, the muscles are excluded from this preparation. That's why you can't find. And cutaneous branches means that they are located in the skin, but not in the muscles. That's why you can't observe it. If we are going to make the proper injection to block the damaged nerve, which technique should we use? And how you can understand that, yes, you are going to the proper condition and the proper direction? Okay, you can use ultrasound, you can use X-ray, you can use any additional techniques, but if your clinic is very poor or you work in middle age, you can use only your knowledge about how this or that nerve should go. So please look at this picture. You can find patient before procedure. We call it intercostal nerve block. So you can find very nice pictures which were drawn by doctor before his or her procedure. You can find the circles, which means what? So what is this? I will draw the red line.
This is the spine.
Spine of what?
Processive spines.
Okay, vertebrae. Okay. What are the other lines? I will draw in another color. So you see some lines with points. What is this?
The ribs.
Ribs. And what these points means? Why they have these signs? Which surfaces of the ribs were drawn at these pictures? We discussed already that we should find the upper surface of the lower rib. But if we find the lower surface of the upper rib, we will go directly to the danger space. So
yes,
this
because here is nerve and arteries. If we do that, it's very dangerous for us.
Okay, so
We said before.
these lines and these crosses means the area of the upper surface of the lower rib. So where we can make this safe injection to be sure that we do not damage the neurovascular bundle. Please look how it goes. We can make the presentation of the layers of the thoracic wall. So we have the skin, the fat, and then we have muscles. We have also, I will draw this area for the safe injection. So if we go very close to the upper rib, we will damage the neurovascular bundle. If we go here, we can find this very safe area, which is also mentioned by the cross at the picture. Let's go back to the patient, and you can find these projections. Can you please tell me how deep you can insert the needle? Which technique can help you to understand that your injection was very proper? For sure, now we need to speak about such procedure as aspiration test. Aspiration test means that when you insert the needle inside the tissue, you can make the negative pressure inside the syringe. You need to take back the plugger of the syringe, and the needle will take the area. It can be air, blood, or some other liquid where the needle is situated. So the negative pressure will take the power back, and you will recognize that if your needle is inside the blood vessel, you will find this blood inside the syringe. And according to this, you need to go a little bit back and change the direction of your needle. According to this, you will find the safe area for the injection, because the blood inside the syringe means that you go to the upper rib, to its inferior surface, but not to the lower rib and its superior surface. Nowadays, we can use additional technique, and at this picture, you can find that the needle is going directly to the nerve. So the idea of the intercostal nerve block is to make the injection in front the nerve, but not into the blood vessel and not to the vein. This is the idea to reduce pain, but another technique I will draw at this picture. If we are going directly to the pleural cavity, we should go straight. Please look, this green line shows the straight direction in the center, but it's much more better to go directly through the rib. This is for the pleural incision. But if we are going to make intercostal block, we need to go through the angle, please look here, directly to the nerve, because we know from the anatomy that the nerve is the last structure of this triplex when we have vena, artery, and nerve. So how to remember in your mind that we have this triplex? It's very, very easy. So please look. V means vena. Another, it looks like a mirror. It is a artery. And if we connect vena and artery, so you see artery and vena in one letter N, it will be the idea of the neurovascular bundle. So vena, artery, and inside the nerve. According to this, maybe it will be easier for you to remember. But going back to the intercostal block, you can find the direction of the needle according to the ultrasound research. It is not enough to make the injection to the thorax, but you need to think about how to go inside the thoracic cavity. And for this, we can find the proper accesses, which has the next title as thoracotomy. Thoracotomy means the surgical procedure which makes the incision through some parts of the thorax. It can be straight or anterior, or it can be postlateral. And according to this, please look at these nice simulators. It's not a real people, it's artificial bodies. Here was made anterolateral thoracotomy, so it goes, possible to say, through the projection of the diaphragm. According to this, to which organs we can make the access? So the anterolateral thoracotomy, let's imagine that somewhere below we have the diaphragm, and upper, somewhere in the fifth and sixth ribs, in this area, we should make the anterolateral thoracotomy to make the access to the thoracic cavity, to the heart, to the mediastinum, and to the lungs. So what else can we make? Which accesses, if we are going to make the operation at the heart or at the lung or at the posterior mediastinum, we can use postlateral thoracotomy. It looks like a smile, like this. It's not a real smile, but it can be a little bit memorized according to the very simple pictures which you use in your conversation. So postlateral thoracotomy, it's the incision which goes through the latissimus dorsi muscle and serratus anterior muscle. We open this smile and we make the proper access to the organs which are included to the posterolateral side. Once again, lung, heart, and posterior mediastinum. At this picture, you can find that some parts were removed. And you can imagine that the sternum and cartilage and muscles and some parts of ribs were resected. And according to the title median sternotomy, so it means the central part of sternum was resected, we make the proper access to the heart and to the structures which surrounds it. Firstly, according to this picture, please tell me about age of this person. Which organ can be very recognizable in the question of aging? Is this person old? Why? Because of what? So why this patient is very young?
The sternum not complete, I think.
No, the sternum is resected here because we have a thymus at the anterior surface of the pericardium. It is here. So the patient is young. We have thymus when we are kids and before the puberty. But after that, we have adipose tissue. So when we were going to make operations because of the reconstruction of the valves of the heart or the trunks and the ascending aorta, we can go through this median sternotomy. You can find at the pictures that the incision is mediastinal, then the access to the sternum, the cartilage which connects the sternum with the ribs are discluded, and some part of the bone is also removed. It can be used in different ways. So for the sternotomy, it can be median sternotomy. Please look, we make the proper access to some valves of the heart. It can be upper, it can be lower, but in most of cases, except the median sternotomy, we save the part of the sternum. In case C, it can be saved for the inferior part and xiphoid process, and for the D, it can be only manubrium and part of the sternum. A very, very interesting question is about hernias of the diaphragmatic region. You should remember about hernias of the abdomen when we discuss inguinal hernia, when we discuss femoral hernia, and hernia of the umbilical ring. But here you can find the very specific parts for the newborn. They have title as foramen morgani, which is located at the sides of the xiphoid process. It is here first. And another one, very big and very possible to say dangerous, Bordalix foramens, which are located in the posterolateral sides of the diaphragm. So what is Morgani foramen? And where we can find this projection at the X-ray? Please look at the X-ray. In normal life, we have this shadow of the diaphragm which goes, I will draw, without any holes, without any foramens, and without any darkness inside. But foramen of Morgani or Morgani foramen we can also call as sternocostal triangles. So these sternocostal triangles means that we have a very weak place in the diaphragm in front of the sternum and between ribs. So about foramen Morgani and Morgani hernia, we need to know that they are also very rare. It's not a regular case for our patients, and thanks God we do not need to be always aware about this condition. But if we have these very small foramens and triangles in sternocostal region, which organs can be the part of hernia which comes from the abdominal cavity? Please tell me, which organs from the abdominal cavity can go to the thoracic cavity via these foramens? It was a question. Not. Okay. If you have no idea, so another disease And another condition is lumbocostal triangle in the lower posterior part of the diaphragm. And the problem is the Bogdalic foramen, which is very, very huge. Please look at the size. This is a real photo from the laparoscopic access. The size of the Bogdalic foramen is very, very big. Which organs can go through this foramen into the thoracic cavity? Do you hear me? What? You should be a little bit brave. It's not an exam, it's a conversation. But all you speak about is much more important, firstly, for yourself. So,
Ascending and descending part of the colon.
okay, let's go a little bit back. Once again, we find the foramen of the Bogdalic at the right and the left side. This is a lumbocostal triangle. So the biggest foramen can be found at the left side. Which organs do we have at the left side? In the abdomen, heart, it's only if you add it. But in normal, heart is located in thorax.
We have pancreas, spleen.
Stomach.
At the
Part of
left.
stomach.
At the left, mostly.
Is it the liver?
The liver.
Liver in normal life is located at the right.
Right.
The stomach we have.
Most part of the stomach, it's fundus. Then it can be spleen if your patient has it. What else?
Pancreas.
No. Pancreas is very nicely fixed below and under the stomach.
Is it the kidney?
So, but it can be a kidney.
Yes.
Okay. According to this presentation, and you see the size of this herniation, you can also tell me which disease and condition can happen with your patient. According to this impression, it's like some part of the stomach or kidney comes inside the thoracic cavity and makes a very big pressure to the organs. So what will happen with the heart?
Collapse.
No. If it's collapsed, it means that your patient will take a one-way ticket and that's all. Okay, the mediastinum can move to the right side because we are speaking about the left foramen of the Bogdalic. Also, the projection of the heart, if you're going to make the auscultation, will also move to the right because the heart with the mediastinum and with the neurovascular bundle also moves. And lastly, the pressure to the lungs will increase because of this foramen. And the only possible treatment is to use the special net. Look, please, it is fixed as it was, if you remember, we discussed in the abdominal cavity the technique of the Liechtenstein when we used the artificial net for the protection of the hernias in area of inguinal or femoral channels. This is the same. We put this artificial material to protect totally the foramen because the size is very, very big and we can't hope that we can use only patient's tissues to close it, because the pressure between walls will be very huge. Lastly, about this first part is the herniation of the esophagus. In the abdomen topic, we discussed with you that's possible to make the vagotomy operation when our patient has reflux esophagitis disease, when the angle between the esophagus and the stomach is not so sharp. At picture A, you can see the normal condition. Please look at the angle between esophagus and fundus of the stomach. At the picture B, the angle is very narrow. And lastly, at figure C and figure D, we have a herniation for the esophagus and for the part of the stomach. And question at this picture is, why it happens? Why do we have condition C and why we have condition D? What happens with the diaphragm or with the stomach or with the esophagus? So, why this disease happens? Are you here?
Yes.
So, why the herniation of the esophagus and the stomach happens? Where we can find the weak places?
Fundus, the part of the stomach.
No, because of the hiatus in the diaphragm delivers the thoracic part of the esophagus to the gaster. So it is located here. How to treat this case? What should we do with patient? The very simple operation, the title is Nissen Fundoplication. So how it works? Please look, we need to take and we need to protect the inferior part of the diaphragm, and we need to make it much more harder. To this, we need to take the part of fundus of the gaster, and we need to fix it to its self-surface, like here. So it's like a special massive parts of the tissue which can help the foramen to be smaller. And also, it can help the gaster not to go out from this foramen. How else you think you can treat? What can you also do to protect the stomach and gaster from the herniation?
Can we cut some part of the stomach?
No. If you cut some part of the stomach, it can be much more thinner and it will be much more easier to go out from this weak foramen. So you can make the plastic for the diaphragm. You can protect it by the net, like here, in some additional parts. But you shouldn't make any resection for the gaster. It works only in case of the cancer. So, how do you understand mediastinal? Is it easy for understanding, or you need some explanation? So no one has questions? So today, once again, I pay your attention to the schedule at 16:15 in the afternoon. Groups number 67 and 66, you have some time to come and pass the, if you have some, not passed abdomen, or if you have additional topics from the other semester, you can do it. For now, we have some time for the chest in case you have questions or if you do not understand some parts. In other presentations, which should be uploaded to the Vkontakte, you will find the mammary gland, lungs, pleural cavity, and operations because of coarctation. You will have it. It is where? In Vkontakte community.
Excuse me, Professor. I went to the previous lecture. I heard you're talking about the operation thoracentesis, but I didn't figure why we use it. Is it to minimize the pressure of the fluid?
Okay, wait. So the operation thoracentesis, wait, I will upload an operation. Okay. So firstly, to understand about thoracentesis, we need to discuss what is pleural cavity and what is pleura in total and what are the functions of the pleura. So pleura is a very thin membrane which covers the surface of the lung. So it looks like the middle shell between ribs and the tissue of the lung. We have different parts of pleura which covers different parts of the lungs. So that part of the lung which is very close to the mediastinum, you can find the proper title as mediastinal pleura. The root of the lung is covered by the cervical pleura. Surface of the lung between ribs and tissue of the lung is costal pleura, and so on. And the idea of the pleural cavity is like compensation of the pressure inside the thorax and inside the lungs. It helps us to breathe during re and expiration. We have such spaces as recesses or sinuses of the pleura, and at this screen you can find the costodiaphragmatic recess. It is located between surface of the diaphragm and the ribs and the wall of the thorax. And always this area is made by the pleura. It looks like the peritoneum for the abdomen. Inside these recesses, you can find the place for the pleural fluid in case of inflammatory process. Place for the blood if we have blood inside the pleural space. And your question about thoracentesis is very closely connected with these pictures. Please look. At the X-ray, you can find lungs. Usually, the tissue of the lung is very, very aired, and at the X-rays, it is dark. But here, in the left lung, we see very white color. This color shows us the free liquid inside the pleural cavity. How to help our patient to remove this fluid from the pleural cavity? We discussed with you the intercostal nerve block when we used the syringe with the solution of local anesthetic to be inserted in front of the nerve from the triplex of the neurovascular bundle to block the pain. But in this area, we need to say that we go inside through the layers of the thoracic wall to the pleural space. The idea of the thoracentesis procedure is to use the technique of aspiration. So you make the negative pressure inside of your syringe and you aspirate the liquid from the pleural cavity. But for the pleural cavity, we need to think about proper access. First of all, we already know with you that it is painful to damage the intercostal nerve. So before thoracentesis, we should make the local anesthesia of the intercostal nerves. The idea of injection is more or less the same with the intercostal block. So you need to put your local anesthetic solution in front of the nerve. After that, please look, your patient should sit. And why it is very important? Why your patient should sit but not lie down at his back or the abdomen or at the side?
To allow the liquid to go down.
According to the gravitation, the liquid will go down.
Yes.
Another type, when we treat pneumothorax, when we have air inside, your patient should do what?
Sit.
It is the same, because the air is very air and will climb up. We will only change the space where we make the incision. For the thoracentesis, we go below. For the pneumothorax treatment, we go upper to the somewhere second and third intercostal space. So according to this picture, you can see that we make injection of local anesthetic, and then we change our syringe and we put our needle inside the pleural space. How to understand that you are not in the lung? How to understand that your needle is not damage the lung tissue?
There's no blood, so we can't feel it when we put the syringe in.
So yes, if you make this aspiration, you will find blood inside, and it means that you are very, very deep. If you take inside the syringe this, okay, it's possible to say yellow solution, it means that this is pleural fluid. And you make your aspiration slowly. Your syringe should be big. It's something like 30-50 milliliters syringe to take all liquid from the pleural cavity. Please tell me, should we work fast or we need to make... No, for sure. Because if we make it fast, we will make a very high decompression for the pleural space and for the lungs. And your patient can easily feel not only pain, okay, it's no pain, no gain. But
discomfort also, yeah.
But high pressure will make another pressure to the heart, and your patient will give you something like a hypertension. That's why it shouldn't be made in a quick way. At this picture, it's the same explanation why you should do it in the sitting position, because the fluid goes down and you can easily take it out. This is the idea of the thoracentesis. The title is from Latin and Greek, so in English it will be pleural injection.
Thank you. Thank you, Professor.
Welcome.
Next class will be same as today.
So
11
the class which is in the afternoon is for your answers if you want to speak about abdomen, for example, for those who didn't pass. Or if you also have additional questions about thorax, you can also come and we will discuss it.
At what time it will be?
In the afternoon, 16:15.
All right. Thank you, doctor.
Next week you will have oral conversation. Topic is chest.
Okay.
And after that we will go back to pelvis, and after you pass the week with chest, you can answer the pelvis. Or if you are ready, you can answer today in the afternoon time. So, okay, if you do not have questions for today, for this hour, it's enough. Please collect your questions more, think something about chest or maybe other regions, and we will meet with you again today in the afternoon.
Okay. That's all. Thank you, Professor.
Have a nice day.
You too. Thank you.